RM3A collects many data points presented in a very easy visual format. It can be used to help you better diagnose and treat your patients. The data points are separated into 8 core areas called risk factors. We'll review each risk factor, suggest possible diseases they help evaluate, and review additional testing that may be pursued based on elevated risk factor measurements. Please note, there may be disease and testing overlap across the 8 risk factors. The first measurement is the ANSD, or Autonomic Nervous System Dysfunction Risk Factor. This can better be defined as a stress assessment, because this data point measures the patient's response to the various stresses that occurred during the testing. Blood pressure, pulse, and sweat measurements are obtained while the patient is standing up, deep breathing, at rest, and during a Valsalva maneuver. If the patient is a very anxious person and has a lot of epinephrine in their system, the risk score will be much higher when being asked to complete these simple actions. The ANSD measurement can be used to determine the amount of internal patient stress that could be affecting other areas, such as cardiovascular health. Although there are a number of conditions the ANSD risk score helps evaluate, the primary focus of this measurement is the possibility of diabetes. Based on an elevated ANSD risk score, the following are possible tests that may be considered for further patient evaluation: hemoglobin A1C, insulin resistance, lipid profile, CMP, complete metabolic profile, complete blood count, additional testing for cardiovascular disease, and ultrasound. The second measurement is the pseudo-D, or pseudomotor dysfunction risk factor. This data point measures the balance between the parasympathetic and sympathetic nervous systems. It shows how well the parasympathetic and the sympathetic systems are being balanced. This test is critical when measuring for a number of diseases, including diabetes, hypertension, depression, anxiety, and other disorders resulting from the nervous system being out of balance. If the measurement is out of balance, then the risk factor will show a high reading, indicating a need to consider causes for the abnormal result, including additional testing. Although there are a number of conditions the pseudo-D risk score helps evaluate, the primary focus of this measurement is the possibility of diabetic, cardiac, peripheral, and distal neuropathies. Based on an elevated pseudo-D risk score, the following are possible tests that may be considered for further patient evaluation: breathing test, gastrointestinal testing, gastric emptying, QSART, urodynamic testing, bladder urinary tract, and ultrasound. The next measurement is ENDO-D, or endothelial dysfunction risk factor. There are a few tests that can detect endothelial dysfunction non-invasively the way this does. Historically, a provider would have to run a patient through an angiogram, CT angiogram, or coronary artery ultrasound in order to arrive at the measurement the ENDO-D risk factor provides. Each of these tests is costly and invasive for patients. In many cases, providers are forced to send patients to cardiologists in order to complete these tests and determine if endothelial dysfunction is present. Although a thallium stress test can identify circulatory function, the disease would have to be moderate to severe in order to see arterial stiffness and diagnose the patient with endothelial dysfunction. If the ENDO-D score is high, this is an indication the patient is showing endothelial dysfunction even if they are feeling well. Their blood sugar is being controlled, the hemoglobin is controlled, or blood pressure is normal. A high ENDO-D score indicates the patient's arteries are getting stiff, and the cells in their arteries are beginning to cause plaques. This can be motivating to patients when they see their arterial stiffness score in black and white. They are much more motivated to lose weight, take their prescribed medication, or control their disease better. Although there are a number of conditions the ENDO-D risk score helps evaluate, the primary focus of this measurement is the possibility of endothelial dysfunction, ANS biomarker of atherosclerosis. Based on an elevated ENDO-D risk score, the following are possible tests that may be considered for further patient evaluation: CRP, additional cardiovascular testing, stress test, ultrasound, and angiography. The next measurement is IR, or insulin resistance risk factor. This measurement shows the chances of a patient having or developing insulin resistance. If a patient who has borderline blood sugar is borderline obese, and you're not sure whether you should tell them they are insulin resistant, this graph will help direct you in one way or another. If the IR measurement is in the yellow or orange, then your patient most likely has insulin resistance. Based on an elevated IR score, the following are possible tests that may be considered for further patient evaluation: blood glucose testing, The next measurement is CMR, or cardiometabolic risk factor. This test checks for cardiac viability. Patients who begin to develop cardiac disease and neuropathy are also prone to develop neuropathy in their hearts. It's a complex process, but patients who develop cardiac disease or cardiac neuropathy begin to lose cardiac viability. Patients with a moderate to high CMR risk score are at risk for sudden cardiac death. These patients will have a very flat modulation of heart rate during simple activities such as standing, sitting, or deep breathing. A high score is an indication that you may need to get more aggressive with the patient's treatment. Patients who lose cardiac viability have a much higher chance of sudden cardiac death in the next 5 years. Although there are a number of conditions the CMR risk score helps evaluate, the primary focus of this measurement is the possibility of high cholesterol, heart disease, high blood pressure, and diabetes. Based on an elevated CMR risk score, the following are possible tests that may be considered for further patient evaluation: cholesterol, blood pressure checks, glucose testing, BG, OGTT, etc., hemoglobin A1C, additional cardiovascular testing, ABI, carotid ultrasound, CBC, complete blood count, and CMP, complete metabolic profile. The next measurement is the SFN, or small fiber neuropathy risk factor. This test picks up small fiber neuropathies well before patients complain of symptoms, and well before it will be picked up by other tests. Though a sweat test is in the palms of the hands and soles of the feet, a high risk score suggests small fiber neuropathy. If the SFN risk score is high, I'll review with the patient how neuropathy can be all over the body, not just in certain areas. Based on an elevated SFN risk score, the following are possible tests that may be considered for further patient evaluation: skin biopsy, nerve conduction testing, and other pain management testing. CAN, or cardiac autonomic neuropathy risk factor, is similar to SFN, but measures cardiac neuropathy instead of peripheral neuropathy. When the nerve damage affects the heart, it's called cardiac autonomic neuropathy. CAN interferes with the body's ability to adjust blood pressure and heart rate. It's not a disease of the heart, but a problem with the nerves that control the heart rate. Having diabetes and high blood glucose levels for many years may damage nerves throughout the body. The nerves that signal the heart to beat faster are called cardiac autonomic nerves. Damage to these nerves may cause a heart rate that stays high, even at rest, instead of rising and falling in response to the body's needs and activities. Another danger is that patients with CAN may have heart attacks without feeling the pain and symptoms that signal a problem. CAN cannot be reversed, but keeping the A1C close to normal may slow its progression. Therefore, it is critical to carefully watch this risk score. Although there are a number of conditions the CAN risk score helps evaluate, the primary focus of this measurement is the possibility of hypotension. Based on an elevated CAN risk score, the following are possible tests that may be considered for further patient evaluation: blood glucose, EKG, echocardiogram, cardiac ultrasound, Holter monitor, and additional cardiac testing. Finally, the last measurement is the PTG-CVD, or plethysmograph cardiovascular risk factor. This is a total cardiovascular disease score based on all of the previous 7 risk factors. If the score is normal but other risk factors are high, it's important that you take into account their age. Although the patient's age could be protecting them from many cardiovascular issues, the process of cardiovascular disease has begun. Reviewing all risk factors with the patient is critical in order to motivate them to make lifestyle changes immediately. There are a number of conditions the PTG-CVD risk score helps evaluate, including stroke, heart attack, cardiomyopathy, atrial fibrillation, endocarditis, aortic aneurysms, venous thrombosis, etc. Based on an elevated PTG-CVD risk score, the following are possible tests that may be considered for further patient evaluation: coronary artery testing, cardiometabolic profile lab tests, carotid total plaque area, LDLP, and BNP, brain natriuretic peptide,